All right. Welcome everyone to the second session of our Health Equity book series. My name is Elizabeth Hart. I am the director of the Office of Faith-Based and Community Engagement at the Tennessee Department of Health. That sits within the Division of Health Disparities Elimination. We are extraordinarily excited about this conversation today, and we're incredibly honored to have our very special guest. As has been mentioned previously, this particular health equity book series has been hosted or is being hosted by the Division of Health Disparities Elimination, the Office of Primary Prevention, and the Health Equity Advisory Team, all three of which are within the Tennessee Department of Health. We are again very excited to have you all here. A couple of housekeeping reminders about today's session. We encourage you, please type your questions into the chat. We will certainly get to them during our discussion today. If you are not already a member of the Tennessee Health Disparity Task Force, and presumably you might have received this invitation either from me or one of the other colleagues at Tennessee Department of Health, we would love for you to join. We have 4 incredible priorities of chronic disease, mental health, environmental health and justice, and infectious diseases. If you're interested in joining our task force, please email me at elizabeth.hart@tn.gov. Again, that is elizabeth.hart@tn.gov. And if you would like to learn more about the health equity and health disparities work that's being done currently at the Tennessee Department of Health, please visit our website, the Division of Health Disparities Elimination, at www.healthdisparitiestn.com. Again, that is www.healthdisparitiestn.com. Again, go ahead and drop those questions in the chat so we can certainly get to those later in this discussion. But I am so honored to introduce our very special guest, and am honored that he's speaking with us from his home in London, Professor Sir Michael Marmot. He has been professor of epidemiology at University College London since 1985. He is the author of The Health Gap, The Challenge of an Unequal World, and Status Syndrome, How Your Place on the Social Gradient Directly Affects Your Health. Professor Marmot is the advisor to the World Health Organization Director General on Social Determinants of Health in the new WHO, World Health Organization, Division of Healthier Populations. He's the distinguished visiting professor at Chinese University of Hong Kong, co-director of the CUHK Institute of Health Equity. He is the recipient of the WHO Global Hero Award, the Harvard Lown Professorship, the Prince Mahidol Award for Public Health, and 19 honorary doctorates. Professor Marmot has led research groups on health inequalities for nearly 50 years. He was a member of the Royal Commission on Environmental Pollution for 6 years, and in 2000 he was knighted by Her Majesty the Queen for services to epidemiology and the understanding of health inequalities. Professor Sir Marmot is a member also of the National Academy of Medicine. Let's give him a very warm Tennessee welcome. Thank you, Professor Sir Marmot, for being here. If you could kind of tell us a little bit about yourself and about your life's work and what you have been doing in the space of health equity.
Well, my pleasure, and it's a great pleasure to be here. I spent much of my adult life, my career, doing research. That's what I did. I did a PhD, I did a medical degree at the University of Sydney and a PhD in epidemiology at the University of California, Berkeley, which is where I started to think about social determinants of health, although we didn't use those words. The words came later. But I was then interested in immigrants, and my PhD was on a study of men of Japanese ancestry living in Japan, Hawaii, and California. And as they migrated across the Pacific, the rate of heart disease went up and stroke went down. So that was for me the first demonstration that the social environment was crucial to health. When I then went, as it were, back to the UK and started studying civil servants at the Whitehall studies, and the striking finding from the first Whitehall study was the lower the grade of employment, the higher the mortality from heart disease, respiratory disease, and a whole range of other diseases, a striking inverse social gradient. And that sensitized me to the issue that when we talk about health inequalities or disparities, we're not only talking about poor health for the poor, but it's a social gradient. In Britain now, in the United States, classify people by level of education or income or the level of deprivation of the area in which they live, classify the area in which they live by level of deprivation. And what you see is a social gradient all the way from top to bottom. The poorer you are, the lower your education, the more deprived the area in which you reside, the higher the mortality and the shorter the life expectancy. Now, that was extremely interesting as a research project. And I spent several years investigating, and I set up the Whitehall 2 study of British civil servants. We demonstrated that social gradient all over the place. And then almost one day, I asked myself, what if people took our research seriously? And I tried to stay out of politics, but you can't. In 1979, Margaret Thatcher was elected Prime Minister in Britain, and her government not only said there's no such thing as society, you weren't allowed to talk about inequalities, just taken out of the language. Orwellian newspeak, no inequalities. So I was doing pure research for 18 years of Conservative government. I was doing pure research. Then one day, the government changed, and yesterday's pure research became today's applied research. What do we know that could make a difference? And that was a signal moment. But the real change for me came when the World Health Organization published the Commission on Macroeconomics and Health. And what that commission said was we need to control major killing diseases in order to get economic growth. And I was doing a mini sabbatical at Trinity College, Cambridge, and Amartya Sen, economist, philosopher, Nobel Prize winning economist, was the master. And I said, Amartya, don't you think that commission got it upside down? I didn't become a doctor because I wanted to improve people's income. And I didn't go into public health because I thought it would help with economic growth. Surely health is a more important outcome than the economy. It's upside down. We want to improve society and the economy in order to get better health. And Amartya said, good idea. I agree with you. I said, should we get a group together to say that? He said, yes. And then he said, it might be useful to get the backing of the World Health Organization. So I went off to Geneva and asked if I could see the new then Director General, J.W. Lee. I did see him and suggested he set up a commission on social determinants of health, which he did and invited me to chair. And that's when social determinants of health really got into the language. We reported in 2008, Closing the Gap in a Generation was the title of our report. And we said on the cover, social injustice is killing people on a grand scale. Bit unusual for a WHO report. So there was a real transition in my life between every paper I wrote finished with the usual bird call, more research is needed. And then everything I wrote after that said more action is needed. I think we do need more research, of course, but the big change was saying we need evidence in the cause of social justice.
Wow. Incredible, incredible. So I guess let's kind of get started on some of the questions that I know were submitted by our task force. So the first question, why should we be concerned about the health gap?
Two reasons. The first reason is most people, and I've got good evidence base to support this, most people are concerned about health. It's high priority. Um, and there is even some evidence, less good, but some evidence that people are concerned about the ill health of others. Um, there's a lot of talk about selfishness and polarization and God knows what going on at the moment. But most people think that it's probably not right if other people suffer ill health through no fault of their own. There's a lot, people on the right tend to blame the poor for having poor health. People on the left tend to blame society. So there's a polarization about that, as there is about everything. But most people think it's probably not right if people suffer ill health through no fault of their own. So we should be concerned about the health gap because health really matters. That's the first reason. And people are concerned about it. The second reason is that all the research and commissions that I've been involved in on social determinants of health provide an evidence base that says that health is a good measure of how well society is doing. And health inequities, and I'll come to the linguistic distinction in a moment, health inequities tell us about inequities in society. So we should also be concerned with the health gap or the gradient because it's reflecting a gradient in society. Health, uh, health equity is telling us something about societal equity. And the linguistic difference is that in Britain, we've always talked about health inequalities. When I started doing work for the WHO, the World Health Organization, we used the term inequities as those systematic inequalities between social groups that are judged to be avoidable by reasonable means and are not avoided, hence unfair. That's why injustice. So health inequity is getting at the injustice.
Thank you so much for that. And just want to remind everyone, if you have a question that you would like to ask Professor Sir Marmot, please drop that in the chat. We will be certainly watching the chat throughout this discussion. So just as a reminder, go ahead and put those questions in the chat. So on to the second question that was submitted by our Health Disparity Task Force. What are the biggest drivers of health inequalities?
Well, in our global commission, and let me say that we did the WHO Global Commission on Social Determinants of Health. And then I was asked to chair 3 regional commissions. One for WHO, as you probably know, is divided into 6 regions. So we did one for the European region, one for the Americas, the Commission of PAHO on equity and health inequalities in the Americas. So that includes North, South, Latin America, and the Caribbean. And the third was for North Africa and the Middle East, the so-called Eastern Mediterranean region of WHO. And our conceptual framework was varied a little bit for these 4 different commissions, but pretty much the same. We had a set of structural drivers which inequities in power, money, and resources drive inequities in the conditions of daily life, early child development, etc., through the life course. And those in turn lead to health inequities. in my English review, so I was invited by the British government to answer the question, how could we apply the findings and recommendations of your global commission to one country, England? Gordon Brown was then Prime Minister of the United Kingdom. And we came up with 6 domains of recommendations, which I think are highly relevant to the United States. Give every child the best start in life. Second, education and lifelong learning. Third, employment and working conditions. Fourth, this is really radical for a rich country. Everyone should have at least the minimum income necessary for a healthy life. They should be able to have enough money to feed their children, to pay the rent, basic income. Fifth, healthy and sustainable places in which to live and work. And sixth, taking a social determinants approach to prevention. What do I mean by that? I said a few moments ago that there tends to be a right-left difference. People on the right tend to blame the poor. They say, you're making bad choices. You've only got yourself to blame for your ill health. Well, what does the evidence show? In Britain, we published in our reports, if people followed the healthy eating advice, the Eat Well guide, for people in the bottom 10% of household income, they would have to spend 74% of their income on food to eat healthily. Don't blame the poor, blame their poverty. That's why they're not eating healthily. They're not irresponsible, they're poor. If people in the top decile of income that would only have to spend 5% or less of their income to eat healthily, if they feed their children fizzy drinks and bad food, they are being irresponsible. So the rich are irresponsible if they behave badly. The poor are poor. And that's, I think we should be able to settle some of these arguments with evidence, which I think is an important part of the story. So that's what I mean by taking a social determinants approach to prevention. One of the things that I learned from the United States, which was hard to apply in Britain initially till we got the COVID data. Let me say a word about where we are now in the UK. And again, I think it's highly relevant to the US. In the decade from 2010 to 2020, the rate of improvement in life expectancy in Britain slowed dramatically. So life expectancy up until 2010 had been improving at about 1 year every 4 years. And then there was a break in the curve. And after 2010, that rate of improvement slowed dramatically. The inequalities in life expectancy increased, and life expectancy for the poorest people got worse. There's only one other rich country that looked worse than Britain, the United States of America. Your rate of improvement was slower than ours. As you know, 3 years in a row, life expectancy in the US declined. Life expectancy for the poorest people in the US went down during that period. And so the question that got asked in Britain, what happened in 2010? What happened in 2010? I said I was commissioned by Gordon Brown, who was a Labour, a left of centre prime minister. He lost the election. We had a Conservative-led coalition government. And their number one principle was austerity, rolling back of the state. And they did it, by golly. Public sector expenditure in 2010 was 42% of gross domestic product, and it went down to 35% by the end of the decade. And the cuts were very regressive. The more deprived the area, the steeper the cuts. Local government spending went down by 16% per person in the least deprived 20% of areas, and went down by 32% per person in the most deprived. Steeply regressive. Then the second issue was COVID, was the pandemic. And COVID exposed and amplified the underlying inequalities. We published the COVID-19 Marmot review we called Build Back Fairer. And what that showed was that the social gradient in mortality from COVID-19 was almost exactly parallel to the social gradient in mortality from all causes. In other words, yes, of course, we need to control the virus, immunization, social distancing, but we have to address the underlying inequalities. And now I'm getting back to the point, the new finding, which wasn't so obvious before, was the high mortality in people by ethnicity, Black, African, British, Black Caribbean, Bangladeshi, Pakistani, and to a lesser extent, Indian. And I was on the BBC when we published these data, and the health minister said he was terribly concerned and people should wash their hands. And I was asked, what did I think we should do about it? I said, washing hands is good advice, and we should deal with structural racism. But what should we do tomorrow? Tomorrow, we should start dealing with structural racism. So for me, this was not quite a new departure, but I was utterly convinced by the evidence. I'd been talking a lot about socioeconomic inequalities. That's what much of my research had been about. But there it was staring me in the face that even after you accounted for socioeconomic characteristics, the mortality from COVID-19 was higher in these 4, 5 different ethnic groups than it was in whites. So we had to think about socioeconomic disadvantage, but we had to think about structural racism, discrimination, and their consequences. Then the third issue is the current cost of living crisis. And inflation, as I'm sure you understand well, if inflation is 10%, the evidence shows that for people in the top 10% of income, it's around 8%. In people in the bottom 10% of income, it's around 14%. Why? Because a high proportion of household expenditure is food and fuel, household heating, energy. And they're items, food and fuel, that are particularly hit by inflation. So poor people are hit by inflation more than rich people. So it's another indignity that's adding to the quality of people's lives. So we've got these three problems: the legacy of what went on in the decade from 2010, the pandemic, and the cost of living crisis. By golly, we're in trouble.
Wow, that was a lot. That was so much for all of us to be thinking about as we are doing this work here in Tennessee. So you kind of touched a little bit about income a few minutes ago, and kind of wanted to bring this question again from a task force member. What can we do to address income inequality?
Well, there's been endless debate, and I've been part of it, is how much does inequality matter and how much is it poverty? And my view of the evidence is yes, they both matter. So at the bottom end, poverty really matters. There was a book in the US, I think it was called $2 a Day, about people who are in the US, in the richest country of the world, that people were essentially living without cash. And that really matters. I mean, if a well-meaning person like me says you should be reading your children bedtime stories, that would be good for their early child development. A reasonable response would be, well, I would if I knew I had a bed, let alone a book. And if I weren't ground down by poverty and just worrying about where we were going to sleep tonight and how to pay the rent, let alone put food on the table. So, yes, absolute poverty really matters, even in rich countries like the United States and Britain. But so does relative income. Relative inequality really matters. We have a gradient in health. It's not just poor health for the poor, it's a gradient in health. And that means that relative inequality matters. And to come back to Amartya Sen, who I mentioned, he wrote once that relative inequality with respect to income translates into absolute inequalities with respect to capabilities. And to translate that into English prose, it's not just how much you have, it's what you can do with what you have.
Wow. Powerful.
And there's a debate going on, at least in Britain, I don't know how much of this is going on in the US, between universal basic income and universal basic services. So, universal basic income says everybody should have an income. But how much income you need depends on what service is available. What do we need? We need shelter, we need education, healthcare, food, transport, connectivity. Broadband is a basic human need now. So those six things are basic needs. Imagine if public transport was free at the point of use. Imagine, as it is in Britain, if healthcare was free at the point of use. Education is now free at the point of use. People opt out. Imagine if nutritious food was affordable, not free at the point of use, but affordable. Whereas now, nutritious food, there's a cost premium. It's more expensive to eat healthily than to eat unhealthily. Then, if we actually provided these universal basic services, the level of income individuals would need would be less. So how much income people need matters. Now, so to get back to your income inequality question, it would be hard to make the case, some try, that there's no link between income inequality and poverty. Well, there is a link. During the pandemic, the number of US billionaires went up from something like 650 to, forgive me if I've got the numbers slightly wrong, 730. Someone can correct me. And that was from March 2020 to October 2021. So in that 18-month period, the number of billionaires went up from 600 plus to 700 plus. And their combined wealth went up by $2 trillion. And poorer people got poorer during the pandemic. So it would be hard to mount the argument that there's no link between inequality and poverty. And quite apart from what I've been talking about, which is inequality not just in income, but in social conditions like basic services that are important for health. So what can we do about it? Let's look at child poverty. If we define child poverty as living in a household at less than 60% median income. Before tax and benefits system, tax and benefits, child poverty in Finland is higher than in the United States and the UK. After redistribution through the tax, notice I used a rude word. I could be declared un-American for using that word, redistribution. Spell it out, redistribution through tax and the welfare system, benefits. After redistribution, child poverty in Finland is 10%. In the UK, depending how you calculate it, it's around 25%. And in the US, it's around 32%. So you've elected as a country to do nothing about child poverty. So pre-redistribution, child poverty would be higher in Finland or Sweden or Denmark than in the United States. After redistribution, it's 10, 11, 12% in those Nordic countries. South Korea, it's 11% in South Korea. And I'm so grateful for the US because you're the only rich country that is worse than Britain. On all the metrics I look at, Britain is dreadful. And then I look at the US and you're worse.
Wow. 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 And I'm seeing a lot of the reactions in the chat as well. So another question from a task force member. We know where you live and where you work matter to your health. What steps should we take to ensure everyone, regardless of their socioeconomic status, has an equal opportunity to live a long, healthy life and level the imbalance of life expectancy disparities?
Well, in the UK and the United States, it's been terribly difficult to get national action. In the Obama White House, I don't think anything got through Congress. The Congress was antipathetic to the president, so it was gridlock in Washington. The Trump White House, I'm of sensitive disposition, so I deal with trauma badly, so the less I say about that, the better. And in the UK, as I said, we had a conservative-led government that was pursuing policies in the opposite direction. So I made a whole set of recommendations, and everything I said, reduce child poverty, they increased child poverty. Increase spending on education, they reduced the per capita spend on education by 8%. Employment and working conditions, we had a steep rise in the gig economy and an increase in in-work poverty. Having enough money to live on, the fourth of my recommendations, poverty went up. Healthy and sustainable places to live. We've got a housing crisis because they didn't invest. And I already told you, in the most deprived communities, they reduced spending by 32% over the 10 years. So local government couldn't do anything. It's all pretty grim. And people ask me, don't you get frustrated? You've been doing this for a very long time, and the government's not doing what you suggest. Well, the English city of Coventry, after my 2010 Marmot review, so-called, declared itself a Marmot city. They took my 6 domains of recommendations and said, we're going to do it in Coventry, whatever the national government's doing. So I went to Greater Manchester. Those of you who watch the Premier League football, soccer, will know these places because they have famous soccer teams. So I went to Greater Manchester and said, Coventry's doing it. How about you do it? I had a meeting with the mayor. So Greater Manchester invited us in and said, we'll be a Marmot City region. And we produced a report, for Greater Manchester, build back fairer in Greater Manchester. Then I went to Liverpool. You know, Liverpool's got another famous soccer team, and they're next door, Manchester. I said, Manchester's doing it. So we were invited into the region where Liverpool is, Cheshire and Merseyside. 3 weeks ago, 4 weeks ago, we published Altogether Fairer in Cheshire and Merseyside. Now we're working in Lancashire and Cumbria, the North of Tyne region, in London, in Wales, in the southeast of England, the southwest. Leeds wants to be a Marmot city. We're working at local level all around the country. It's really exciting. And the hypothesis, the assumption that they're pursuing is regardless of what national policy looks like, we can make a difference at city regional level. On my 6 domains of recommendations: early child development, education, employment, having enough money to live on, healthier, sustainable places, and helping people adopt a healthier lifestyle. And the evidence from Coventry is they are making a difference. We've got a set of Marmot beacon indicators for these cities, so we'll know if it's working.
Wow. I've got a couple of questions. Thank you for that, Sir Marmot. I've got a couple of questions in the chat. First, what do you believe is the catalyst for change? And in that, before you answer that, this individual also said if poor people have to work all the time and have no health care, when would they have time and energy to join together for organizing to exact change?
Yeah. Well, they're two terribly important questions. And let me approach the second one first. I agree with the premise of the question. It is incredibly time consuming to be poor. If you've got $20 to spend on food, you go into the supermarket and it takes a very long time because you're totting up the prices. Can I afford this? Can I afford? Oh, it's $22. I'm going to have to go back and put something back and maybe get a cheaper version of that. And we've got a brilliant writer on these issues in Britain and who has lived through poverty herself. And she knows what it's like. She says she goes into the supermarket with £15 to spend and it takes her 45 minutes. And somebody comes in who doesn't have to worry about the money and they're in and out in 15 minutes. And if you're worrying, can I put food on the table tonight? Can I pay the rent on Friday? Oh my goodness, my child needs a new pair of sneakers. What am I going to do about that? That's incredibly intellectually demanding. And it's, as the phrase people have used, it reduces the intellectual bandwidth. You have to spend so much time actually worrying about the mechanics that somebody with enough income doesn't have to worry about. Can I get the car fixed? If you've got enough income, you get the car fixed. If you haven't got enough income, you say, will I get the car fixed or buy my child that new pair of shoes they need? Because that's the choice. Wow, that's incredibly time consuming and very stressful. And that stress has big impact on the next generation. Children who grow up in that stressful environment, their early child development is damaged. And that kind of stress and the impact on children's brains can persist through the life course. That means you can't just say to individuals, go and join a group, do it. You've got to address these key drivers, my 6 determinants, and it needs organization. It needs local government, the voluntary and community sector, to get organized, not for some individual who's got all of these worries that I've just been setting out, and to do it on their own or with their next door neighbor. It doesn't work. But I'm really excited by where community groups have got together and well-organized groups get together to support each other and make a real difference. So absolutely right with the question. No, poor people don't have the time to join a group, but well-organized groups can help poor people meet some of these basic needs. You notice I avoided the first question. How do we get that political change?
Yeah.
Well, anybody who cares about democracy is going through existential angst at the moment. When I say to my American colleagues, I talk about the problems we're having in Britain, and they say, we're not listening. You think you've got problems with your democracy. You should see what's going on with our democracy. And I've tried not to be party political in Britain. And you can probably tell that most people blow my cover. They can tell where my predilections are, but never mind. But I've said I'm willing to talk to the government. I'm willing to talk to the opposition parties. The government doesn't seem very willing to talk to me, but there we are. And I was briefing the shadow cabinet, so our Labour Party. The story is probably apocryphal, but after the war, the Labour Party in Britain, the leader went to the US and he came back. This is going back 2 generations. And he said they have two political parties in the United States. The Republican Party is a lot like our Conservative Party, and the Democratic Party is a lot like our Conservative Party. But that was going back 2 generations. It's all a bit different now. But so I was briefing the shadow cabinet of the Labour Party, so the people who will be the cabinet secretaries if Labour gets back into government. And I was going through my recommendations and what I thought they need to do, and they were terrific. They were really excited. And then one of them said to me, we're not very good at getting our message across. What advice can you give us senior politicians at how to get our message across? I said certain things come with age and experience. And one of those is knowing what I'm no good at. And I'm no good at telling politicians how to get their message across. But I can tell you what I do. I tell the truth. I argue from the evidence. And I engage people in a spirit of social justice. Now, if you tell me that's ineffective, you've got to be a rich person who gets into a smoke-filled room and give money to a political campaign or whatever. I can't do any of that stuff. I don't know how to do that. What I know how to do is tell the truth, argue from the evidence, and make as strong a picture as I know how for social justice as a driver of what we're trying to achieve.
Wow. Wow. I'm completely speechless right now. You are incredible. We have a question in the chat. In your opinion, what do you think has been the biggest driver of change for women's health over the last several decades? And what new challenges do you expect to face women's health in the near future?
Well, as you could, I hope, tell, I'm a hopeful person. I'll come back to that. And so I look at what's happened and I see the positives. If I were less hopeful, I'd say, a whole various waves of feminism, where have we got to? So I see the positive. I'm not blind. I see the negatives as well. So I know the pay gap, the gender pay gap, which persists. It's unconscionable, indefensible, but the gender pay gap persists. Glass ceilings, they persist. No question, in the US and Europe. But that said, there's real advance. I told you I look at health as an outcome. And in low income and middle income countries, there are many countries where women's mortality is higher than men's. That isn't true in the rich countries. Women's mortality is lower than men's. And there have been real advances. Now, there's still a huge way to go. So let me, for example, give you an example. We had a group of visiting Europeans and Eastern Europe, Scandinavia, and so on, visiting, and we took them off to East London. This was a few years ago. For state-provided childcare, it cost £11,000 a year, maybe $15,000, something like that. So if you've got two children, it could cost you $25,000 for state-provided childcare. Well, in that part of London, so median income was about £27,000. So if you're spending somewhere between £11,000 and £20,000 on childcare, what? In that part of London, the income was less than the median. You'd spend every penny that you earned on childcare. Now, who does that fall on? It falls on women. Overwhelmingly, not exclusively, some men are the carers, but overwhelmingly it falls on women. So there have been enormous advances in women's health because of the advances in women's social and economic conditions. But then, whereas in Sweden, the equivalent was about £1,000 a year for childcare, not £11,000. Women could go out to work. And that has a number of effects. One is it reduces child poverty if both parents are working, and they only have to pay £1,000 for the state-provided childcare. Both parents can work. The childcare is relatively cheap. No wonder child poverty is low. Secondly, women are empowered. They have their own income. That member of the male persuasion can't keep me here because I've got no independent earning power. If he misbehaves, I'll leave. I've got my own earning power. And that's very important. So I think the advances that have been made in women's social and economic position has been crucially important to their health advancement. It doesn't mean that we haven't got a further distance to travel, and we do. And it was pointed out to me that, so I did these, well, I've done several now. I did the 2010 Marmot review in England, and then I did a 2020 review, Health Equity in England, the Marmot review 10 years on. And women suffered more than men did over that 10 years because something like 2/3 or more of the austerity affected women, because the cuts in family support tend to affect women more. And all of those cuts had a bigger impact on women than on men. So we need to keep our gender equity focus. We need to keep our racial, ethnic focus, and we need to keep our socioeconomic focus. Someone's going to use the word intersectionality in a moment, but we need to keep all of these in focus.
Absolutely. Another question from the chat. We all know that addressing social determinants of health are vital in narrowing these health gaps, but when we're facing a healthcare system that has difficulty even admitting implicit bias and structural racial disparities exist within their practice, How do you suggest we start and where to even begin? This individual would love your opinion on where they can begin.
Well, the US has got to get civilized. Um, you're the only rich country that doesn't have universal health coverage. Um, it's it's quite remarkable. Um, I remember once going to New York, and there was a baseball match going on between two New York baseball teams, and it was called the World Series. And I thought, this really is an odd place, this United States, when two New York baseball teams play each other and they call it the World Series. Well, I think it's pretty odd that a rich country that spends an enormous proportion of its GDP on healthcare doesn't have universal health coverage. So that ought to be the starting point. That shouldn't be a left-right issue. It shouldn't be. I mean, just look at what every other country does. And they're not Marxists, they're not communists, they're not whatever garbage gets labeled. They're just civilized. That's what you do. When people get sick, they shouldn't be deprived of access to health care. Good heavens. So I don't know. I mean, there's other things I don't understand. Why you guns. I don't understand that either. Um, but the question wasn't about guns, it was about universal health coverage. That ought to be a sine qua non. I really don't get it. It's bizarre. And you shouldn't have to be Bernie Sanders to say we're for it. Everybody should be for it. That's part of living in a civilized society. Universal education, universal health coverage. It's a basic.
Absolutely. So you've mentioned Marmot cities a couple of times, and we've got a question in the chat. What do cities have to do to become a Marmot city, and that can they in the United States?
Well, look at our website. What we've not done, um, we've been asked a few times, um, could you write it down? What do you have to do to become a Marmot city? Could you write it down? And so far we've resisted it. But the cities in England that have become Marmot cities have taken my 6 domains of recommendations that I've spelled out twice or 3 times already this evening and said, we're going to do it. So it's not just the healthcare system, that's important, but we're going to do it. Early child development, education, it's important. And what motivates us is the social justice imperative of setting right these inequalities in health because they're wrong. We shouldn't have them. Where they're avoidable, they should be avoided. So we're in the process now of setting up a network so that there could be mutual learning. So in a way, the question, I mean, look at our Institute of Health Equity website. All our reports are there, so you can see what we do. And before lockdown, before the pandemic, the year before, I think, I was invited to the Italian city of Trieste because the invitation said, we are an Italian Marmot city. I had to go. Then I got invited to the Italian city of Bologna. They said, we are an Italian Marmot city. I had to go. Then the penny dropped. I said to the person who'd invited me, do they know they're a Marmot city? No, of course not. I just said that to get you here. But so forget the Marmot part. But what they were doing was very much what we're recommending. At the city level, they were dealing with housing, with social assistance, with integration of migrants, with early child development, with education. In Trieste, they had these teams of healthcare people, early child development and education, and social assistance. And they would have teams of these three that would go into, they called them nano, sort of micro areas of the city, where the teams would go in together to try and help deal with the issues of health inequalities. So I'd say what you need are two things. You need the specifics, and we've laid them out in our reports, but you need to be animated by a spirit of social justice.
Absolutely. So before we get to our final question, before folks depart from this conversation, we want to thank you again, Professor Sir, for Marmot, for coming on and talking with us. We've got folks on here from across the country, mainly here in the state of Tennessee, but we do see a couple of our federal partners on here. And so we want to recognize those individuals and those organizations. And if you are wanting to get involved with the task force, the Health Disparity Task Force here in Tennessee, please go to our website, healthdisparitiestn.com. Certainly send me an email at elizabeth.hart@tn.gov. So I wanted to put that plug in before the last few minutes in this last question. Within the task force, we are doers. As we spoke before this conversation began, we are action folks, right? In the communities at the local level, what can we do as a group, as the Health Disparity Task Force, to make change within our own individual communities?
Well, let me repeat myself. Read our reports. I mean, do go look at our website where we are working with people who've asked that very precise question. And it needs adaptation. You can't do for Tennessee what we've done for Manchester in the same way. The principles can be the same. The evidence base is similar, but you've got to work with communities to adapt to your local context. And let me finish by coming back to something I said. I was hopeful. I used to go around the world saying I was an evidence-based optimist. And a Brazilian colleague heard me say this, and he's in his Brazilian Portuguese. He said, "Michael, you are using the English language incorrectly." Okay. He said, "You're not an optimist, you're hopeful." Go on, I said. Well, an optimist believes things will get better. Their prediction is that things will get better. You're hopeful. You're not predicting that they'll get better. You're hopeful that they are. And I thought, wow, that's wisdom. And it's more appropriate to talk about being hopeful because we can then change things. We shouldn't sit back and say, I wonder if the future will be better or worse. Let's be hopeful. And yet to come back to your question, let's use the evidence of what can make a difference to change the future so we can be hopeful that we can make a difference. And all the evidence suggests that we can.
Once again, thank you, thank you, thank you so much for coming and having this conversation with us. Thank you again to the Division of Health Disparities Elimination, the Office of Primary Prevention, and the Health Equity Advisory Team, all within the Tennessee Department of Health, for helping to host this and sponsor. Professor Sir Michael Marmot, again, thank you, thank you, thank you. We will be sure to send out all this information in the website links that he mentioned. Again, if you would like to join our distribution list for the Health Disparity Task Force, email me at elizabeth.hart@tn.gov. Thanks so much, everyone. Have a wonderful day.
Bye.
Trying to stop recording.